Okay, let's dive right into a clinical deep dive on two really important menstrual disorders, amenorrhea and its cousin, hypomenstrual syndrome. If you're in the medical world, this is stuff you absolutely need to have in your diagnostic toolkit.
So here's our game plan. We're going to start by nailing down the definition of amenorrhea. Then we'll break down the difference between its primary and secondary forms. After that, we'll get into the really interesting part, mapping out all the diverse causes. We'll walk through the diagnostic pathway, and then wrap things up by getting a handle on hypomenstrual syndrome.
All right, first things first. Let's define our terms. What exactly is amenorrhea? What does it really mean when a period just stops, or maybe never even starts?
So what's the clinical line in the sand? Well, amenorrhea is the absence of menstruation for 6 months or more in a woman who's in her reproductive years. You know, that 6-month mark, that's the key trigger that tells us, okay, time to start digging.
Now, right off the bat, there's a huge distinction we have to make. Is this physiological or is it pathological? In other words, is this a totally normal, expected absence of a period, like during pregnancy or before puberty, or is it a red flag that something else is going on? This is basically the first fork in the road on our diagnostic journey.
Next up, we've got to ask a really fundamental question that completely splits our diagnostic path in two. And that question is, has this patient ever had a period? Seriously, the answer changes everything.
So on one hand, you have primary amenorrhea. This is when someone's first period just hasn't shown up, and we usually start looking into it around age 15. On the other hand, you've got secondary amenorrhea. This is when established periods just stop. And notice the different clocks on these. We're talking 3 months for someone who was previously regular, but we give it 6 months if their cycles were irregular to begin with.
Okay, this is where we put on our detective hats, because it gets really fascinating. We're about to map out all the possible causes, and they can come from literally anywhere along that neuroendocrine axis. We're talking from the brain all the way down to the uterus.
And this flowchart, this is our roadmap. It lays everything out so clearly. You see that big split at the top between physiological and pathological? And then on the pathological side, it branches out even more. We're going to use this structure to explore all the different places this problem can start.
So let's start at the very top, in the brain. The control centers, the hypothalamus and the pituitary, are super sensitive. I mean, things like an energy deficit from crazy amounts of exercise or weight loss, major stress, or a hormone-disrupting tumor. Any of these can basically just tell the whole system to shut down.
And believe me, this isn't some fringe issue. A study from just a few years ago really brought this home. Look at that. Almost 75% of women with hypothalamic syndrome had menstrual and reproductive problems. It just goes to show how central the brain is to this whole process.
Wow! I mean, this chart just says it all, doesn't it? Look at that massive gap. Over 87% of the women with hypothalamic syndrome had cycle issues, compared to less than 25% in the control group. That's a powerful visual of just how critical a healthy hypothalamus is.
Okay, so if the brain seems to be working fine, we move down the axis to the ovaries. The problem could be right there. We're talking about things like genetic conditions. Turner syndrome is a big one. Or premature ovarian insufficiency, where the follicles run out way too early. And of course, there are complex hormonal imbalances like we see in PCOS.
And finally, sometimes the issue is purely anatomical. You can think of it as a plumbing problem. The entire hormonal orchestra might be playing a perfect symphony, but if there's a blockage, like an imperforate hymen or scarring inside the uterus from something like Asherman syndrome, well, the blood has nowhere to go.
So we've got potential culprits in the brain, the ovaries, and the uterus. With a differential diagnosis this broad, how in the world do you tackle it systematically? Where do you even begin?
Rule number 1, the absolute first, non-negotiable step every single time. Pregnancy is the most common reason for secondary amenorrhea by a long shot. You have to rule it out before you do anything else, period.
After that, it becomes a really logical, step-by-step process. You always start with the patient's story, their history. That's where you'll get clues about stress, diet, or exercise. Once you've confirmed they're not pregnant, you move on to some initial labs. Checking FSH, LH, TSH, and prolactin gives you a fantastic snapshot of that whole axis. And then finally, imaging. A pelvic ultrasound lets you check out the anatomy, and if the labs are pointing toward the pituitary, an MRI can give you a closer look.
Okay, let's shift gears just a little bit and talk about a related condition, hypomenstrual syndrome.
The way to think about this is that it's on the same spectrum as amenorrhea, and a lot of times it's the precursor. So what is it? Well, it's a whole spectrum of what a patient might just describe as lighter periods, or maybe they're just coming less often. It's not a complete absence of a period, but it's a definite change from their normal, and that change can be the very first sign that something's up.
And for us clinicians, we need to be precise, right? So we have specific terms for this. Hypomenorrhea is all about less volume. Oligomenorrhea means the bleeding time is shorter. And when we talk about frequency, opsomenorrhea is for infrequent cycles, while spaniomenorrhea is for really rare ones, like just a few times a year. A patient can have any mix of these.
And here's the kicker. Here's why this is so important to catch. A lot of secondary amenorrhea cases don't just happen overnight. They start as hypomenstrual syndrome. It's a warning sign, you know? It tells us the system is under stress and might be heading towards a complete shutdown of menses.
So, we end on this really crucial thought. These conditions aren't just variations of normal to be dismissed. Understanding this whole spectrum, from a period that's just a little bit lighter all the way to full-blown amenorrhea, is absolutely key to early diagnosis and intervention. It lets us ask the right questions and find the root cause before it gets worse. So the real question is, are we listening closely enough to these early signals?